We're located in Worcester, Massachusetts. And primarily our clients are based in the New England area. So New England has been for quite some time, probably maybe a slower starter to reference-based pricing and RVP products, although we are definitely starting to see an uptick in the RVP activity, in particular in the state of Connecticut, Vermont, some in Maine as well. And Kelly Jackson, who's joining us from Payer Compass, is going to be going over kind of some of the finer points of reference-based pricing, along with their solutions for an RVP product that we partner with them on. And so we're looking forward to her delivering her remarks in regards to that. But just to let those folks know that are attending, what we'll do is a little bit of housekeeping as we continue through the session here. If you want, feel free to submit questions as we go along. I do a pretty informal type of webinar. This is being recorded. We will share this with those that have attended and with those who probably registered but could not attend. We'll also get a recording of this along with the presentation. So as far as questions go, feel free to submit them via the chat function here through Zoom, and Kristen or I will go ahead and monitor that, and we'll pause throughout the webinar to be able to answer any questions, because I feel that it's the best point in time instead of waiting till the end. Again, UltraBenefits is poised to help consultants obviously work with their clients who may be interested in reference-based pricing, educate their clients on what it is, the savings that it can bring, but also really the whether it's a fit or not for the client. I think that that's probably the most important thing to understand, because it does really take all parties to understand what they're getting into and the advantages of it. And obviously buy-in from the top is the most important. So with that said, I'm going to go ahead and turn this over to Kelly from Payer Compass, and she's going to deliver the rest of the presentation. And just as a reminder, if you have questions, feel free to use the chat feature here on the Zoom app. Thank you. Kelly?
Thanks, Brian. I appreciate inviting me to speak with you and your team up there in the Northeast. I'm calling in here from Dallas, Texas. As Brian said, please, if you have questions, put them in the chat. And Brian, if you'll monitor that, because I'm not going to be looking at the chat, but if you'll monitor that and then punt some questions to us as we go, it's better than I agree than waiting to the end. So again, thanks for joining. My name is Kelly Jackson. I'm Vice President of Sales and Client Engagement here in Payer Compass. We've been partnered with UltraBenefits for several years now. And today's session really is just to, I'll take you to the agenda here. Talk about what is RVP, reference-based pricing. If it's new to you, and it is relatively new to the Northeast, really talk about what is RVP and how does it work. What should your employees and your members expect on this kind of plan. Really talk you through how Payer Compass does reference-based pricing, our integration with UltraBenefits. Got some case studies to share with you on savings, balance bills, stats, those kind of things. And then really talk about what differentiates the various RVP vendors out there, because there are several players out there and some good ones, but want to talk to you really about what sets Payer Compass and UltraBenefits apart from the rest. So, and then we'll have time at the end for more Q&A too. So with that, what is RVP? So reference-based pricing, really, it's you don't have a network. Now, many plans, I think ones that we have with UltraBenefits actually do have a physician network in place. So we're really doing RVP mostly for facilities, but you could certainly do it for all providers, institutional and professional. But it is paying providers a reasonable rate based on a Medicare percentage of Medicare, a multiple of Medicare in the plan document. So you really don't have any network. So therefore you can go anywhere. But really the three components we're going to talk about today about what makes an RVP plan. Pricing the claims is what we do for UltraBenefits. We provide patient advocacy, and then certainly assist members when they're encountered with a balanced bill. But why are we here? Reference-based pricing, getting away from a large VUCA network, you're going to lower your cost, your claim cost out of the gate. No network, members can go anywhere because everybody's really considered in network, which is lovely. Transparency, you have full transparency into what claims cost, fees, what providers are charging, what are you reimbursing, what are their charges, equate to a multiple of Medicare, et cetera. Let me move my screen here so I can see, sorry. And you can really plan. You can plan your costs for the plan, whether it's an administrative cost, your claim costs, you're going to get lower costs on your stop loss renewals going to a reference-based pricing plan. So really it is about lowering costs, but then at the same time, giving members access to any provider they would like to go to within reason, and giving them full access. So we're going to drill down a little bit more into really, members' experience. How does it work? Because we've all been conditioned for 30 plus years with HMOs and PPOs that you have to have a logo on a card and it tells you where to go. You have to have a network to stay in. So as soon as you remove that Buca network logo off the card, people say, is this real insurance? And it is. But we just have to do a lot of education, and you'll hear that throughout. It's really educating the member, and the education comes from the plan, the employer. Education comes from you, the advisor, consultant, broker, your third-party administrator partner, UltraBenefits, a lot of education there. And then Payer Compass. When we're on the phone with a member and a provider, we're doing more education. So it is really, this is a new way of providing, healthcare and covering those costs than we've ever done before. So it's something new. Takes a lot of education for your membership to understand really what this is, and it is real insurance. So a member's journey. Members go get care when they need to get care. We have a team, and we'll talk through a little more detail the process, but we have a team of folks that will make outreach on your members' behalf. We also have tools called Compass Connect where members can self-serve or navigate to see an area which providers are more friendly to RBP. So, we do reference-based pricing for plans all across the country, and we source all of that data to provide information to members when they log into Compass Connect as to is this hospital friendly or not? Have they balanced billed historically? Information like that. We pull in quality scores. So really trying to allow members to self-serve, but we also have a patient advocacy call center. Members call in and we make calls, outreach on behalf of them before care. A lot of that's done on the professional side, and if there's a network in place, then there's less outreach on physicians that are inside, let's say, a PHCS network. But let's say you have a member going to somebody that's not inside the PHCS network. We will certainly make outreach to that provider, trying to ensure access and answer any questions the provider has. And then the member goes and gets their care. And the provider drops the claim comes to us, we price it at the multiple of Medicare that the plan has set. So Payer Compass doesn't dictate that, but we certainly give guidance to the plan and to UltraBenefits as to, in different markets, what are we seeing that is acceptable. So you really want to set that dial, that multiple of Medicare, in a range where we can optimize savings for the plan and still reduce the noise of balanced billing as much as possible. So there's a balance or a sweet spot. You can't reduce all noise, but you certainly want to reduce it as much as you can manage. And then the provider's paid, and we'll show here in a second with some stats. About 98% or more of claims come in, get priced. UltraBenefits pays those providers according to the plan document, and the provider accepts the payment. There is a small percentage of claims that are balance billed. Some of that has been reduced a little bit by the No Surprises Act for emergency care, but still, there's going to be some claims that are balance billed. So if you're talking to folks, in the RBP world, and it says, we'll guarantee you'll never get a balance bill, well, I'd be cautious of that, because balance billing does occur across our entire book of business. When you look at all professional and facility claims, we see about a 1 to 2% percentage of all claims that do result in a balance bill. But unlike a network, when a member gets a balance bill and there's no one to help them, we have a process. We have a team of people here to assist members with balance billing. So we assign, number one, a dedicated representative to a member. So that our representative stays with that member through the life cycle of the balance bill. We work with the provider to get it written off. Sometimes getting it written off is not doesn't happen, and we have to go to a settlement process. But we stay in constant communication with UltraBenefits. If it involves the stop loss carrier, then those folks are pulled in as well when we get to settling a balance bill. Talk about in a minute. We're integrated with the FIA group. They're our partner in our RBP program, and they help us with those really difficult or sticky balance bills that we just can't get resolved at Payer Compass. They'll step in, we escalate it to them. But we have a dedicated member that's a representative that stays with that member through the life cycle of the balance bill, whether Payer Compass is working on it or the FIA group is working on it, until we get to a resolution. Again, a resolution would be it's written off or it's settled. Is really, as far as we want to go. But we'll talk about FIA's got some additional add-ons for prepaid legal, things like that, if a plan really wants to go that far. But kind of high level, that's the process. Members go get the care they need. Claims come to Payer Compass. We price them, and then we're there on the back end if a member does have, a balance bill that needs us to work. So that was high level. Digging in a little bit deeper in the process. So when a plan comes to us, the first thing we want to do is look at the SPD, the ID card, and the EOB. And we've done this with UltraBenefits. So all of their plans would follow this process, but we make sure those three documents are in harmony. So our partner, the FIA group, actually reviews the plan document. We want to make sure there's no holes in that document. We want to make sure the SPD states how the RBP plan will run, because we don't want to leave a loophole for a provider to say, aha, I gotcha on the back end if they're challenging us with a balance bill. So it's important to review those documents up front, make sure they're buttoned down tight so that the plan can operate the way it's intended. Again, I mentioned we've got advocacy, patient advocates that work with members and providers all day, every day to help with access. Single case agreements sometimes come up. This is the team that will do that. If a member's having issue with access. We already are fully connected with UltraBenefits, all the integration there. Claims come to us, repriced, sent back to UltraBenefits within a matter of minutes. Really, it's all in production and running very smoothly. Then when a member gets a balance bill, well, members get a lot of things, and members can be confused because this is a confusing industry. If a member gets what they believe is balance bill, really we have the member reach out to UltraBenefits first, because we need to make sure that it's really a balance bill and it's not a portion of the member's responsibility. It's not part of a copay or deductible. And I'm going to pause here for a second and talk about plan design, because plan design is very important with reference-based pricing. And it's something that as advisors and consultants, I think you should think about. Trying to do a reference-based pricing plan on the old Buca chassis of a high dollar, $5,000, $6,000, $8,000 deductible. While we have clients who do it, it doesn't work as well, because what happens is everything hits the deductible, and then the people are wondering, well, I'm paying for everything, the plan's not paying anything, and so you're asking members to make a change. You're asking members to use tools to help them self-serve and to navigate and to be involved and to stick with us when we're working on a balance bill. But then, it really, your claim costs are going to go down. Shifting that idea of a $5,000, $6,000, $8,000 deductible into something more reasonable that your members can meet, not only helps the member, but it also gets the provider's eyes open to saying, hey, let's look at this RBP plan. For instance, whether it is gaining access with a single case agreement or it's fighting a balance bill in the back end, plan design matters. Because what we could argue with a provider, and we do, is that, Mr. Provider, I know you want your Blue Cross discount, and that's what you're looking for, and you may not love 150% of Medicare, but how much of that Buca discount are you really collecting? You're chasing that member down for $5,000 who we know is never going to pay or going to pay very slowly. Whereas on our plans, much more reasonable deductibles. Some of our plans have no deductibles. They manage everything through copays. So therefore, this is first dollar payment from the plan. You're collecting some nominal amount up front from the member. And therefore, it is easier to turn a provider to get them to agree to accept the plan payment because they've got cash in hand. They're not chasing a member for an unreasonable deductible that no one's paying. So rethinking plan design, if you're going to put an RBP in place, is key. Again, we've got plans who won't rethink it. They say they can't rethink it, and they use the same plan design on RBP. It's just harder. It's harder for the plan, for the member. Certainly, we don't have the leverage when negotiating with the provider that we would if we had a more richer plan design. So I would encourage you, the savings you get with RBP, rethink plan design, make it more of a benefit for your members. They will appreciate it, and it will also help a lot. It'll help a lot when you're trying to have some leverage with the provider arguing the level of reimbursement. So anyway, going back to the little flow chart here. So the TPA, which is UltraBenefits, will verify the member has met their deductible, their copays, and if not, then they will direct the member, this is not really a balance bill. This is part of your deductible. You need to pay this. But assuming the members met all their responsibility, UltraBenefits will then hand over that balance bill to Payer Compass. And from this point on, it's really our job to work that balance bill. We keep in constant communication with the member, the provider, and UltraBenefits as to where in the process this balance bill is. When you hand us a balance bill, it doesn't go into a black hole. We've got it in a database. We've got status codes on it as it moves through the process. And resolving a balance bill is a process. I mean, when you look at our entire book, on average, we resolve balance bills in about 90 days. Some of them, certainly, first phone call day one, get it taken care of. But some of them, are on the other side of that 90 days. There's a lot of negotiation back and forth. It's really dependent on the provider, how quickly they are to return, proposals and calls back to us. But throughout this process, we have a dedicated rep that stays with the member. We have a touch point with the member every 2 weeks, whether it's through our Compass Connect app, whether it's a phone call, a text message, letting the member know where we are with the balance bill. We certainly contact the member more frequently as soon as there's something material to report. But even if the provider is still considering our offer, we still touch base every 2 weeks just to keep that member engaged. Because, again, education is key. Members, if they get a balance bill, just can't shove in a drawer and leave it. They need to get it into the system and let us work it. Because clawing back a balance bill that has sat there for a year and is now with collections or the credit agency is harder. We do it, it's harder. As balance bills come in, if they're if they give it to us, we get them in the system and work them, it's a lot easier to work a balance bill that's fresh than one that has been passed off to an outside collection agency. So Payer Compass works the balance bills. Some are written off, some are settled. Ones that we cannot resolve, we escalate to the FIA group. They're our partner in this. They're part of our fee structure. We'll talk about in a minute. But they're there. They have resources. They've got certainly attorneys on staff that work on claims that will then also fight these balance bills and work on negotiations. Part of our program, fully integrated. But even when we hand a case escalated up to the FIA group, it's our advocate Payer Compass that stays in contact with the member. We don't pass the member off to the FIA group. We think it is good customer service to have one person tied to that member through the life cycle of their balance bill. I mentioned before, FIA has some relatively new in the last year or two, some more programs that you can add on to Innovate 360, which is our reference-based pricing program, some prepaid legal, some Shield programs. So that's a topic for another day. Or I can put you in touch with the FIA group if you want to know more about that. But it's an additional level of service for folks who really want more legal recourse. But again, our goal is to get a balance bill written off or settled. We don't want to have to go to what people hear about and rumors are about all the lawsuits. I mean, that's other people are in that game. That's not the Payer Compass model. It's not UltraBenefits' model. We want to get balance bills written off or settled, so that we don't have to go to that final step. And then ultimately, the TPA reimburses the provider. If we make a settlement, again, not our claim dollars, so all settlements are approved. We work through UltraBenefits, which pulls in the plan, the advisor, stop loss carrier if it's needed, and we all talk about it. Payer Compass is given approval to sign on the dotted line on a settlement. Then UltraBenefits will pay that additional claim cost and we'll close that case. So we're never going back to the member to say, we've negotiated another $2,000 on your behalf. It is the member's balance bill, but we're doing this on behalf of the plan. So any additional settlements will come out of claim dollars, and UltraBenefits will reimburse the provider on behalf of the plan.
Kelly, if I could kind of just kind of inject some or add a little color, going back to what you were just talking about a little bit regarding plan designs, and the importance of really setting up the proper plan design, and just to share with some of the advisors and consultants that are on here. You know, I can share with many of you that in instances, and just to kind of get you to understand why these high deductible health plans that you typically will see with most of your BUCA networks don't really work well, is just, you know, we recently had a particular client who did have, unfortunately, had a higher deductible. I think it was around $5,000. It was a $5,000 individual deductible. What happens is, for example, just so everyone understands the importance of richer plan designs and what it does, is, you know, if they wouldn't have had an emergency care event, it was around a $6,000 bill. So we obviously, that claim gets sent to Payer Compass for repricing. Once it got repriced, the claim was about I think about $1,800, right? It was repriced according to the plan at whatever multiple Medicare that the plan chose. Let's call it 150%. So it's it went from a $6,000 bill to an $1,800 bill because of the repricing, but the deductible was $5,000. So what did the member owe? The entire amount, the $1,800. And when that happens, you know, it's really difficult to explain to a member that, well, you know, you owe the whole thing because it's part of your deductible responsibility. And then what ends up happening is the member gets this negative impression of the health plan, and it really then ultimately defeats the entire purpose of what the employer was trying to do, which was really ultimately deliver a positive health benefit to their employees, all the while trying to save on overall plan costs for the employer. If you take that same situation and you put in a $1,000 deductible, let's say, or even a $500 deductible, I'm actually seeing a lot of $0 deductibles. In that instance, the member would have only owed $1,000, the plan would have paid the remaining $800 balance, and everybody would have been happy. So you can kind of understand, you have to understand how the claims get repriced, what it means to the member, how does it bump up against their deductible responsibility, and who owes what. So the lower the deductible with RBP plans, the better and more positive experience the members will get, number one. Number two, you're also delivering a richer benefit package, okay? And you're also delivering a benefit with open access, meaning they can see any provider that they want anywhere. So to stress the importance of plan design and to kind of piggyback on what Kelly was saying is extremely important when you're getting involved or offering an RBP product. And I just want to have an opportunity to share with those here on the webinar today the experiences that we've seen and some of the pitfalls, obviously, that we've encountered with clients and or advisors and consultants who want to stay that high deductible health route. Hopefully that kind of added a little bit of color to what we were expressing in regards to plan design, and gives you kind of future thought when entering into this type of financing for healthcare, is to really do it right and do it right the first time, so that everybody has a positive experience that's involved, both the employee and the employer. So Kelly, thank you. I'll turn it back to you.
Sure, Brian. Very important pieces, and I'll just add a little bit more, not to beat the dead horse here, but using your example, I think it was charges of $6,000. The plan allowable under an RBP plan was the $1,800. So what happens in that scenario when that member has that $5,000 deductible? The plan doesn't pay anything because it's all hits member deductible, and so the member gets a balance bill. Really, the provider is going to send them a bill for $6,000. That's the full bill charges, and then they're going to turn it and say, okay, Payer Compass, now can you go work on the difference between $1,800 and $6,000 while the member sets up some kind of payment plan to pay, $100 a month till that's paid off? Well, the answer is no, because what happens is we call the provider, the hospital's been paid zero, nothing, because it all hit the deductible. Member hasn't paid, plan hasn't paid. So the provider did a service, outpatient surgery or something like that, and they've gotten paid nothing. So why would a provider ever negotiate with us when they have $0? And this is the one time that I would side on the part of a hospital I wouldn't negotiate either. So what has to happen in that scenario is the member's got to pay their $1,800, which most members can't write a check for that on day one, but pay the $1,800. The provider will then recalculate the claim. And in many cases, they'll say, okay, now I have been paid the full plan allowable. I may not love it, but I've been paid it, and I'm going to write off the rest. If they don't, and they recalculate and they continue to balance bill the member above the plan allowable of $1,800, then that certainly is a balance bill will work. But that is the rub there, because in the interim, the member is getting a bill for $6,000, and the provider will not negotiate the difference because they've been paid zero. So again, a lot of talk on plan design, but it is key to having the most successful reference-based pricing program. We certainly have clients who refuse and can't think and can't change it up. And we'll do RVP, but I just go in saying, just so you know, this is what's going to happen. Everything's going to hit the deductible. And really at the end of the day, very little comes to us. An inpatient stay kind of claim, but most of your outpatient stuff is all going to hit the deductible, and very little is going to come to Payer Compass to work. And that's not really how the plan was designed. You want us to get those balance bills and work them. Okay, moving on. So Payer Compass, let's do some highlights here. So we price a lot of claims. Now, certainly 2.8 million claims are not all RBP claims. We do a lot of claims also in the health plan space, managed Medicaid, Medicare Advantage, VA claims. But the reason I put this stat up here is to show you that when it comes to reimbursement, we process a lot of claims. It also helps us with what I'll call gap. Medicare has rates for lots of things, but not near everything on a commercial plan. Childhood vaccines, DME codes, certain surgeries in an outpatient setting versus the inpatient setting. But our experience in all the areas of reimbursement help us put a defensible rate on those, what we call gaps. The FIA group knows how we handle those kind of things. They write in the plan document. So, using Payer Compass UltraBenefits, you're not going to get claims that price to zero or something that falls out and hits some kind of percent of charges like I've seen other folks do. So we can price those claims. As I said, 98+% of claims are accepted by the provider. So very little pushback. Not that it's not important, because if it's your balance bill, it's very important. But in the grand scheme of things, I think when people hear the noise, they need to take it as to what percentage of claims this really is. And it's a very small percentage of claims, still a lot of balance bills for us to work across our whole book of business. But for an individual plan, a very small percentage of their claims are going to have that noise. On average, when you look at all our claims, about 72% of the claim is you're going to get a reduction off charges. It's even higher on outpatient facility and inpatient facility, but we're throwing in there all the professional claims, which does lower that percentage down. We got a lot of plans who do RVP for all professional and institutional, but so on average 72%. But if you're just doing it for facilities, you're probably in the 80s. And again, you're going to have lower claim cost, stop loss premiums, etc. So let's talk about this safe harbor thing here. So at Payer Compass, this is what we call a heat map. So we're just showing in an area, what our experience is, not just for your plan, not just for UltraBenefits, but for all of our experience across the country. As Brian said in the beginning, Northeast, relatively new to reference-based pricing. So if I ran a heat map for, say, Ohio or Texas, man, it's covered in blue and green dots there, and a lot of yellows too. But Northeast is relatively new. So just I put up Connecticut here to show that while it doesn't have hundreds of thousands of providers, the blues and the greens, which mean blue is a provider who somebody in our universe has a direct contract with at an RVP rate. Greens are providers who we have made outreach to. The plan doesn't have a contract, but the provider has raised their hand and said, yes, I'll accept this reference-based pricing rate. I won't hassle your member at time of access, and I'm not going to balance bill them. So as you can see, a lot of blues and some greens, and then the yellows are showing where, most providers aren't contracted in an RVP plan. Most providers have not been spoken to, and they haven't raised their hand that says, yes, I'll balance bill. What the biggest number on our heat map is typically the yellows. And what that shows is in our universe, an RVP plan of ours has submitted a claim. We've priced it. the TPA has paid it, and we don't show any record on the back end of that provider balance billing. So in essence, they are taking that RBP rate. We kind of consider the green, yellow, and red like a stoplight. So whether it's the member looking at our Compass Connect tool, or if I run a heat map for Brian to give to a consultant who's looking at an area, green, yellow, red. Green, go, those providers accept RBP. You should feel safe going there. Yellows, cautionary. We have positive experience in the past, meaning they have taken an RBP rate, we've priced claims, TPA clients have paid claims with no pushback. And then reds are providers where we have seen balance billing on the back end. Not to saying those balance bills can't be resolved, but they have balance bill in the back end. So this is how we list our, we call them safe harbor providers. Again, this information in Compass Connect is available to members at a more granular level, but I run what we call heat maps as a sales tool to give to brokers, consultants. You work through UltraBenefits. When you're looking at doing it in an area, I can drill down to a county level or multi-county, or even widen it out here to the state. But when you look at all these providers, a little over 2,600 providers, 96 of them are either blue, greens, or yellows. So when I look at that, even though Connecticut, relatively new to RBP, very high percentage of providers willing to accept a reference-based pricing rate. Okay, let's get to some case studies. So here is a steel manufacturer. So we got 250 people on the plan. You can see the number of claims, number of charges, et cetera, down below. Very low balance bill rate, about 1%. Again, this plan is doing a professional and facility. Even when I add in settlements, there's been some settlements on those balance bills. You're still, without the settlements, it was like 76% savings to charges. Even when I add in additional payments for a few settlements, you're looking at 75% of savings to charges. Again, professionals added in here and facility. And nothing has gone past a settlement. We've either gotten it written off or we've gotten it settled. So this is a typical use case. We have plans that are single digits. We have plans that are in the thousands, but that 1 to 250 is typically kind of a sweet spot that we're seeing most of our plans come in at. But we do, people ask, what size plan does Payer Compass take? And we don't have a minimum. It's whatever your UltraBenefits or your TPA partner would have. Yeah, some folks don't go down to the single digits, but we have plans in the single digits. But this one's a 250 plan. Again, been running on the plan for a couple of years, and let's see, since April of 21. So a little over a year, and they're seeing a very low balance bill rate and a lot of savings. Now this totally different end of the spectrum. This is a large school district, very large school district. That's using reference-based pricing as a tier 3 solution. So almost out of network. They've got in their market, it's a large school district in the Southeast. They have got a direct tier 1 is a direct hospital that's got multiple facilities. Then they've got a narrow network in their market, and they're using reference-based pricing only for tier 3 out of network. So they've been on the plan since October of 20, showing you some savings there based on year. I think I ran this report back in April, so it's not a full, that's year 2 is October 1 through April 19. But breaking it up by claim type, inpatient, outpatient, ASC, professional, et cetera, and the savings. So they are operating at a fraction of the balance bill rate and huge savings on out of network.
Kelly, we do have one question out there from Stephen Breitbart. For the balance bill situations, if the provider will not agree to terms, does the employer pay the cost?
So if we have a balance bill and we are trying to get the balance bill written off or come to a settlement for additional dollars to get it taken care of, and we can't resolve that, we push up to the FIA group, they try to negotiate, and the provider ultimately says, nope, we are not negotiating take it, this is what we want. We want full charges. Is that what we're talking about here? They just refuse to settle?
Yeah, I would imagine so. So for instance, let's say the plan reimburses at 150% of Medicare. We send them that payment. They're like, not good enough. We get paid 350% of Medicare from our Blue Cross contract. That's what we want. So we know in most instances the highest we'll go up to is what's the ceiling? 180% of Medicare. So we're a little off, and they're willing to accept the 350. Does the employer have the ability to pick up the remaining costs?
Certainly. So we don't dictate that. Most stop loss carriers will allow us to negotiate really without having to come back for permission up to 200% of Medicare. But every plan is different. Some plans and some of our clients want us on every single negotiation for $10 to come back and say, can you agree to $10 more? So most plans, their stop loss carrier would say, Payer Compass, you're paying $150. You have freedom to negotiate up to 200% of Medicare before you get to come back. Because typically that's how stop loss contracts are written, so that they'll cover anything up to 200% of Medicare. But having a good stop loss partner in this who understands reference-based pricing is key, because they will know there's going to be a fraction of claims that are going to be settled above 200% of Medicare. Again, it's not every claim that's balance billed, and it's certainly not every negotiation. But if you have a claim that the provider says, I will only take X and not $1 more, and if you don't pay that, I'm going to continue to balance bill the member. I'm going to ding their credit. I'm going to take them to court, whatever. Then the plan certainly can say, on this claim, I do want to settle, and I'll and working with the stop loss carrier, I will pay X multiple of Medicare. People get tied up in this percentage of Medicare sometimes, because you have to take it with what the balance bill is. 350% of Medicare on a $2,000 claim, certainly different than 350% of Medicare on $1 million claim. So, you drawing a line in the sand that says nothing above this percentage. Again, if it's a low dollar claim to make this balance bill go away and you're over 200% of Medicare, really, it's a $2,000 bill. Let's think about the dollars here. Big difference if that's 350% of Medicare on a huge claim. So again, every claim is unique and different. Every provider is different. We look at our experience. How far have we pushed that provider in the past to get the best deal? So we work very closely with UltraBenefits, who then will work with you, the advisor, the plan, the stop loss carrier, to get the best outcome. But at the end of the day, this is the plan's dollars. The plan can decide to choose to pay or not pay however much they wish to. We will just offer guidance, our experience, market intel as to what the best possible deal is, but it's ultimately the plan's decision. We do not dictate that. Hope I answered that question.
Yes, very good. Thank you, Kelly.
You bet. Okay, RBP differences. So what's a lot of folks out there doing RBP. So number one, Payer Compass is a PEPM shop, per employee per month. So we're a subscription model. We have a contracted rate with UltraBenefits that they pass on to the plan. So there are others out there in the market who tie the RBP vendor's fees to charges, either as a percent of charges or a percent of savings. I'm not sure how either one of those models lower claim costs and healthcare dollars for the plan. I don't get it, because charges are unpredictable. And I have seen in many cases where if you're paying a vendor a percentage of charges, then you've paid that vendor for one claim more than you paid the hospital that provided quality care to your member. I don't understand what universe that makes any sense. So Payer Compass is a subscription, PEPM, we're an admin fee. So get that cleared up right off the gate. Payer Compass supports direct contracting between the plan and the provider, if it makes sense. Now, of course, a big hospital is not going to go contract with, Joe's Automotive and as an employer with 30 people. They just administratively can't do that. But we support it, whether it's on the front end, single case agreements, it's on the back end when we're working on a balance bill. Let's say we're working on the second, third, fifth balance bill for a plan with the same provider. If we can get that provider to agree on a direct contract, then we help facilitate that. We don't hold the paper. We're not part of the contract. We just help bring transparency and help facilitate that contract between the plan and the provider if it makes sense. We have tools, Compass Connect, a tool that allows members to self-serve, look for RBP-friendly providers, compare quality scores. We pull in CMS quality scores. Shoppable codes is a regulation coming in next year. Again, that's all going to be done through our tool. That's a differentiator. Also, our method of communicating with providers is not adversarial. You know, we're not here when we call a provider to talk about a balance bill to say, hey, I'm going to sue you before you can sue us, Mr. Hospital. That's not our shtick. There's others in the market who do lots of that for everybody, and it really kind of gave RBP a bad name. So we are here just to explain the facts. When we're on a phone with a provider trying to talk about a balance bill, we're just trying to get them to a place to discuss a reasonable, fair rate. And basing that rate off the charge master is not a good starting point. So we want to turn the conversation around, talk about plan design, how this is first dollar payment. And yes, Mr. Provider, you want your Blue Cross discount, but how much of that are you really collecting? Because that Blue Cross discount comes with $5,000 deductible that nobody's paying. So it's having those conversations with providers, getting them to turn the corner into what's acceptable, what's fair and reasonable. And it's not, you know, we're not here to try to sue people. And so that's a big differentiator in the market. Payer Compass is fully integrated with UltraBenefits. We get eligibility files, we get claim files, we send those back. They're not touched. It's fully in production, automated. So that piece is done. So bringing on a new case, pretty simple. There's a form to fill out. We need some demographic details, but on the Payer Compass side, with all that, I call it plumbing, claim files, eligibility files, all that, it is very little for Payer Compass to do to bring on a new case very quickly. Also fully integrated with the FIA group. They're our partner in this. As you saw on the front end, they review plan document, ID card, EOB, making sure all those important documents are harmonized. They're there on the back end if we need to escalate a claim up to them because we haven't gotten the provider to move. Our system, the FIA group, Payer Compass systems are updated, I don't know if it's minute by minute, but certainly every day, so that Payer Compass can see any updates the group has done to a claim, and vice versa. We pass a case up, the FIA group is not starting from scratch. They have all of our history as to what we've said to the provider, what letters we've sent, et cetera. So fully integrated there. And again, the FIA group has some additional programs, you know, for some plans who want to adopt those. Again, it's more insurance, prepaid legal kind of things that we can add on to a plan if a plan really wants more protection. All right, Brian, that's all I had prepared, but happy to take any other questions the audience has, if any.
Sure. So thank you, Kelly, so much for presenting on Payer Compass and really the advocacy and I think the difference in the model that Payer Compass uses for reference-based pricing compared to many of the vendors that are out there in the marketplace who just take that tact of we'll see you in court. One of the other ones you'll find too is in really kind of researching RBP vendors. Be very careful on how they charge. I know that Kelly had referenced on the last slide that they're a PEPM model. So that's a fixed cost, right? It's just an administrative fee versus many RBP vendors do a percentage of savings. Keep in mind, whatever size of that claim is and whatever that percentage of savings is, 20, 30%, you have to keep in mind that when you pay that percentage of savings, let's say it's a $10,000 bill and it's a 30% savings, and you have to pay $3,000. That's got to go back in to the aggregate claims under that stop loss contract. So as that continues to happen throughout the year on these types of claims, that could ultimately and unwillingly, or unwittingly, I should say, put somebody in a situation where they could potentially have an aggregate hit. We completely avoid that entire chance of that happening by simply putting in place this PEPM model with Payer Compass, which is one of the very reasons why it really attracted us to this partnership with Payer Compass. It's a major differentiator out there in the marketplace. So just keep in mind when working with vendors in this space, just be careful as to how they charge. It's really important because it really can negatively impact your client. And at the end of the day, if you don't flesh that out, they're going to turn around and point the finger at you as the consultant. for not vetting out that piece of the process. So,
Brian, to add
opening
on to
up
that.
the questions.
I'm
Yeah,
sorry,
sure.
Brian. Stop loss carriers hate that percentage of savings, percentage charges model because they don't have visibility into it. So you will, working with good stop loss carriers who understand our reference-based pricing, and you're with a partner that's a PEPM, you will get a lower stop loss quote versus somebody that's tying their fees to the charge master. Sorry to interrupt.
No, it's a great point too. It definitely impacts pricing on stop loss. We have some of the premier RBP stop loss carriers that are out there that we work with, that also Payer Compass is very, very familiar with. So there's there's a lot of synergy between obviously UltraBenefits, Payer Compass, and the very particular stop loss carriers that we use when it comes to reference-based pricing. So having those three components really builds a very positive RBP plan that we can offer to you and your clients. So well said there. Do want to give a few more minutes for the folks that are on. If you want to go ahead and submit a question through the chat, now would be the time. But as as we continue to talk through this, there are probably some hopefully many opportunities potentially for your July 1 renewals that you might be thinking about doing this for. Obviously, anywhere between July and October, which is another popular renewal month. This would be of great interest. You can work with myself or Kristen Kaceris, who's on here also from UltraBenefits. We'll be more than happy to help facilitate and get you an RBP quote, and kind of go over the savings that it would present. And then really once that's done and if a decision's made, like Kelly said, everything's set up. It's a plug and play. We've done all the heavy lifting, all the hard work. It's just merely educating the client, showing them the finer side of reference-based pricing, and really reiterating the advocacy that's built in within the program to really take the member out of any potential balance billing, which is far and few in between. We haven't seen any within our book of business to date. So we have been very, very successful as of right now in working with Payer Compass and our clients who are on RBP plans. So with that said,
Brian,
I will,
Brian, one thing I forgot to mention, talk about, renewals. So part of the service that we work with UltraBenefits on is providing a savings model. Now, it is contingent upon you getting your clients' paid claim data, which if they're with a big carrier, it's harder. Cigna, Aetna, sometimes you can work and get the claim data. Blue Cross, United, very difficult. But if you can get the claim data at a claim line level, UltraBenefits has the spec really, at the line level, NPI, HCPCS, CPT codes, etc. We can take that claim. It's part of our service. We take that file in, we'll reprice it, and we'll show you what the savings at a claim, at a provider level, at a claim, inpatient versus outpatient. We will show you the savings of that provider's actual claims for a year or 2 years, or however much data you can get. Getting the data is hard from those carriers. I get it. But if you can get the data at a line level with all the details we need to perform a really good Medicare pricing, we can actually take your exact paid claims and show you what the savings would have been under an RBP model. Very powerful. We can talk about savings all day long, but when an employer sits down and looks at their claim cost last year versus this year, or a carrier versus an RBP plan, very, very impactful.
Yeah, and we've done that actually for several different clients. We worked with Kelly to get those repriced, showed them the savings not only on the variable side of the claim cost side, but obviously the dramatic impact it has on the fixed side with stop loss premiums. So to see how much you can save in claim cost is a huge eye opener, and it really it puts the power back where it belongs, really, which is in the hands of the employer. It's their money. Our healthcare system, and we all have come to know this, there is a perverse incentive within the healthcare system between the providers and the insurers, where there is this little bit of gamesmanship going on, and as far as the discounts that are being received, obviously then the carrier having to pay out those claims, and then justifying their double-digit increases year after year. That train is not going to stop. There's nothing to stop it. It will continue to happen. The only real way to kind of deliver or really get some type of cost containment is to return the power back to where it belongs, which is really in the hands of the employer group. It's their money, frankly, at the end of the day, and they should have the ability to negotiate just like our federal government does when it comes to claim pricing. So as you can see, my bias is coming through, but I'll leave it at that. I'm passionate about this. I've seen so many success stories year after year, throughout my 25+ year career within healthcare financing and employee benefits. I am a believer in this. It works. And again, if interested, you want to learn more, or you think that you have a client or prospect that might have an opportunity to take a look at RBP, let us know. We'll be more than glad to help you. So with that said, I don't see any more questions out there. Kelly, I really want to thank you for the time and really sharing your time with us, I should say, and just really being really detailed on what reference-based price is, how it works, kind of seeing what the pitfalls have been throughout the years in the industry, and kind of the best practices is to make a successful plan. So thank you so much for your help and your presentation here this morning. For those that are in attendance, once again, we'll go ahead and forward you this recorded webinar along with the presentation. And again, continue to look forward to more, more opportunities to present different types of ideas that are up and coming out in the marketplace on how to help your clients, ultimately save money and put the power really back where it belongs, which is within the hands of the employers and employees. That's what we do at UltraBenefits. It's what we're passionate about, and it's really what we're here to do and help you with. So once again, thank you, everybody. Enjoy the rest of your day. Enjoy the long Memorial Day weekend. Best to all, and everyone have a great day.
Thank you.
Thank you.